Thank you for joining us for this Karga debate, Scroll Prompt Study, How Young Doctors Find Answers and Consume Medical Content. This is the second in our Karga debate series. Our first one asked the question, are we sacrificing substance for speed? Where we looked at peer-reviewed manuscripts versus short-form bite-sized media. And that was really taking a look at it from the pharmaceutical perspective. Today, we're going to do something that we don't often do, or at least not as much as we'd like in the pharma industry, and asking real doctors how they consume medical content, and specifically the use of AI in their clinical practice and education. So let me click on. Here you see our disclaimer. So the views here are our own and do not necessarily represent the institutes we work for or indeed Karga publishers. We have a great faculty here today. I'll briefly introduce everyone and ask them to introduce themselves when it comes to their sections. We have three colleagues from the University of Freiburg, Professor Heinz Windel, who's the professor there, and also co-founder of Prof. Valmed, Dr. Cora Koch, who's responsible for medical education as well at the university, and Tim Schwar, who's a medical student at the university. We also have Meenakshi Jala, who's an academic physician at King's College London in the UK, and also my colleague Frank Varga from Karga Publishers, and he's head of medical education and engagement. Before we get into the presentations, we want to ask you a question. So if you can fast forward your minds 5 years to 2030, we want to know, how do you think AI will most transform the daily lives of young physicians? Do you think it's going to be a supercharged research assistant where it handles literature reviews, medical writing, and grant requests all in a matter of seconds? Do you think it's going to be a medical co-pilot where it decodes lab results, scans, all in the context of patient histories to give you accurate diagnoses and personalized treatment plans? Do you think it will be a virtual administrator where it joins your consultations, summarizes notes, and even helps with patient communications and booking appointments? Do you think it's all of those and then some? Who knows what's going to be available in 5 years' time? Or are you more skeptical? You're still not buying it. AI won't be a game changer, and regulatory hurdles, the law, and skepticism will hinder widespread adoption. So we'll move on to our poll. Hopefully that pops up. There we go. So I'll give that a second for you to vote, and I can see the answers. Maybe you're not seeing them. I don't know if you're seeing them, but there's one clear winner here. It looks like folks have stopped voting. So let's end the poll and share the results. There you go. Can you see that? I'm not sure if you can see it, but on my screen, I can't see it any longer, but there was 70% of you think number 4. There were a few skeptics, but a few votes as well for answers 1 to 3. So we're going to find out what real doctors think of AI, how it's being used now and in the future. So the key questions we'll address today, and I do encourage you to submit your own questions through the Q&A button at the top of your screens in the webinar tool. So we're going to be asking, how are Gen Z HCPs using AI today? Are they using it for education and for clinical decision making? And how do they assess the credibility of the information sourced with AI tools? What are the implications of using AI to support clinical decision making, and does it meet the definition requiring regulatory oversight? And we'll also talk about medical content and scientific information and how doctors are finding information using AI tools. So broadly, our discussion is going to focus in 3 areas: clinical, research, and education. So Professor Windel will talk more about the clinical aspects of using validated sources of information using AI tools. Meenakshi is going to kindly share some research she's been doing at King's College London and Imperial College using AI to predict risk in patients. And Cora will talk about the use of AI as she's using it both in provision of medical education and also with students, and we'll get Tim's insight into that at the panel discussion. So here's a summary of where we're going to focus our discussion on, and I've highlighted a few tools out there already. It's impossible for me to keep track. I'm sure there's an AI tool that can keep track on all the health-related AI tools that gets released every week. But broadly, we're going to be discussing clinical, education, research, and administrative AI tools. So Prof. Valmed, I've already mentioned, and Heinz is going to talk more about that. It's a CE certified AI tool to support clinical decision-making using validated sources of information. Sanome's a company working on AI tools to predict risk in patients with neurological disease or damage. Open Evidence, you may have heard about that being called the ChatGPT of health, and already 40% of doctors in the US have signed up for Open Evidence, and around 100,000 institutes in the US. And even general purpose LLMs like ChatGPT are becoming more capable in terms of health-related queries by HealthBench, which is its own benchmarking tool. And then you have tools which are more focused on the research, but also moving into the clinical side of things, such as MedPalm 2 from Google, which now scores 85% in exams. So a doctor, a human, would score around 60%, which is a pass mark, so already on average outperforming humans. UpToDate has just been updated with its own Gen AI tool, which now allows you to use to interrogate its database of information. We already know that LLMs, general purpose LLMs, are being widely used to support medical writing. A recent report from Cornell University showed that in 2024, 13.5% of abstracts showed some signs of LLM input. However, the citations used with these kinds of tools are not the most trustworthy and need to be checked. This is why you have more specific medical writing tools such as Consensus and Cite. Probably the most impact AI will have in the immediate term is going to be on the administration side of things. So both for doctors and probably for us as healthcare users of those services. So for example, you might have seen Microsoft Dragon Copilot, which is being rolled out in places like the NHS, where you would use, or AI would join clinical consultations and use ambient voice technology to take down notes in those discussions, write up summaries, even maybe suggesting clinical diagnoses, and even going so far as to issue prescriptions. Here's some data from a recent report from IQVIA, and some of you, or many of you, probably joined the call a couple of weeks ago. This is their biannual survey of HCPs and the pharma industry, and they asked the question specifically of HCPs, 326 doctors, do you use AI for scientific information? And 54% yes, they do. And this was the first time that they saw LLMs being used in as the preferred digital channel. So here you see ChatGPT, for example, at 46%. Google remains number one at 93%, but Google, of course, has its own AI tool in its summary. So when you do a search, so whether Google is Google in the old sense or whether that also incorporates AI as well, I'm not entirely sure. But what's clear is that AI usage is increasing, and that's definitely split by age. So people born after 1990 use it more than those before 1990. Specifically on what doctors use AI for, they believe it helps them make better treatment decisions, so 72%. So that's either reassuring or worrying, depending on the way you look at it. Gen AI also makes it easier for doctors to find information. So 94% find information more easily. However, they are checking the sources of information, and this is at 86%. So this will probably decrease as the trust in the citations becomes higher. So if you look at the bottom, the trust in the scientific information sourced is only at 38%. So hopefully that sets the scene. We'll now move on to the presentations. I'd first like to welcome Professor Windel to talk a little bit about the use of validated AI as a medical co-pilot. Heinz?
Yeah, Aaron, thanks for the intro and thanks for having me here. Hello to all of you. For me, this debate is a very interesting one, and it touches, at my opinion, into something extremely critical, which is the question, how do we really retrieve information, and how do we navigate in this jungle of information, medical pluriverse, I call it. Can I drive the slides by myself, or can we move forward the slides? I mean, all of you are in some way confronted with the question, if I have a certain problem, being it trivial or more complex, where do I get the information? It's being said that one key achievement by having undergone a, let's say, university exam is you don't know what you really were asked in these exams, but you know where you would like to look it up. And this has changed dramatically over the last years, that it's not anymore textbooks with a, let's say, kind of a very little dynamics in knowledge. Medicine science is exploding, and it's absolutely impossible to keep track to that. It's becoming also more complex, more multidimensional, multiple technologies. And if you just look into an area where I'm in, like neurology, which is one specialty in medicine, we have subspecialties, which is, for example, neuroimmunology, where I'm specialized in. And even here, it's impossible to really keep track on all the developments, approval of new therapies, and so forth. And this is not becoming better. I mean, we're looking at a demographic development where there is expectedly aging population with more health issues, with more expensive therapies, more interdisciplinarity. So how can we really keep up with this? You've seen in the introduction by Aaron that there is a, let's say, arrival of AI-assisted tools. And the question is really, where are they and how are they really arriving in daily practice? Next slide, please. So this is the starting point, basically, where I now, a bit more than 2 years ago, decided to go into a founding of a company that is exactly tackling this question. So the world knowledge, and this is what I'm talking about. I'm not talking about patient-specific data. I'm talking about world knowledge in medicine, is full of different types of knowledge elements. And while it's rather easy to access knowledge via things like Google or ChatGPT, it's not validated. And when you look at different levels of validation of knowledge information, then you make different criteria depending on in what education status you are. So if you're a student, then it's not that you're deciding on a diagnosis and a treatment, but when you're a board certified specialist, then you're liable. And then actually your information should also have this type of a liability. And what happens is that this is a pretty big jungle, and what really usually an information should be, it should be validated, it should be evidence-based, it should be, in the end, liable as a recommendation to support treatment or diagnosis in a patient, physician or healthcare professional interaction. Next slide. This is what we reasoned when we started this Professor Wallmed. And the idea is really that a power of AI is to have this combinatorial brain, if you want to call it, which doesn't fatigue, which doesn't forget, which has everything on the table. And if you look at what neurologists usually doing, they are mixing a puzzle of different types of information and modalities. And they are dealing with probabilities of this could be the diagnosis of this and that. And this is an ideal use case for a co-pilot. So a multimodal composite of different types of information, imaging, lab results, patient anamnesis, clinical examination, and then you're getting helped by a data repository, which is supported with a combinatorial and conversational power of a large language model. This is the starting point where we said, well, this is where the normal textbook is coming to its limits because it's usually very sequential and monodimensional. Next slide. This is what we then used as a starting point. And if you do the same in classical LLMs, they are not really purpose-driven towards a medical applicability. They are not danger approved. They are still prone to hallucinate. And that was something we decided we would like to overcome for a trusted use. We call it a new class of medical AI. It's trustworthy, explainable AI. Next slide. What we did is we decided we built a database that is very transparent, which is a closed database and which represents the most relevant elements of world knowledge. And if you really think about it, to make a proper diagnosis or a proper treatment, then you are depending mostly on things like guidelines or regulatory documents. It doesn't help if you have a textbook that is from 1960 because the diagnostic criteria of many diseases have changed. And this is why actuality, but also the level of society agreement on certain types of diagnosis is more relevant than, let's say, general knowledge. And this is why we built a medical data architecture analysis module, which is our database, as a basis for Professor Walmid validated medical information. Currently, it exists of 2.5 million documents. They are all human curated, they are validated, and they are not prone to any bias in terms of there is no publisher bias, there is no pharma bias. It's just trying to represent the most neutral 3 to 5% of medical world knowledge. And this is then technically a RAG augmented knowledge retrieval system, which means that a closed database that is updated and curated is interacting with an LLM. And the endpoint where we had to prove that this is working was a clinical evaluation plan where we had to do a clinical trial like you're approving a drug. And the notified body, which is the approval instance for those type of medical devices, was asking to be presenting a calculated number of being safe. And this is why we call it safety index. So the theoretical possibility of something happening when you directly execute what our Walmid clinical decision support system would provide as an answer is currently 0.26. We are often getting asked, how does this benchmark against general purpose LLM? And what you can see here is for diagnosis across different specialties here, gynecology, internal medicine, neurology, pediatric surgery. Professor Walmid does as good as ChatGPT does with the current versions. So that means it performs equally good in certain tasks, but it is liable. And the other thing is, next slide, is that the depth where you're dealing with, the more specific the question gets. For example, if you're digging into a very specific question to a drug, you need specific documents in a retrieval situation. And this is something the general purpose LLMs, partly, they know a lot, have not been trained on, except for not being liable. The other thing is, and this is also part of the discussion today, is the community ready for that? Do they know how to deal with it? And this is exactly why we built in parallel an education platform, because AI incorporating tools are a pluriverse as well. So what is the LLM? What is the database? What are you specifically intending to answer? You will hear from Meenakshi, a specific application, and a lot of things is not really generative AI. So our tool is not AGI, it's not a learning system, it just uses the power of reproducibility and combinatorial and conversational power of an LLM, but it's not a learning system, because you would like to have the same answer answered the same way, because it's not changing. The diagnostic criteria for a disease are not changing, so you shouldn't be creative here. So creativity is not what we are asking. It's really being helpful. And this is why we created a education platform, which we call the Medical Valmed Academy. And those two things together are the so-called Valmed universe. So it is also something we have to educate on. And the three key concerns of now opening AI usage to any healthcare professional or earlier stages or anybody is a de-skilling. So you're losing skills that you once had. It's a mis-skilling. So you're deviating, and this is particularly relevant if you're getting outside of your area of competence. So because AI usually sounds pretty plausible. So we're having unskilling, de-skilling, and we have mis-skilling. This is the three dis-skillings that we have to be concerned of. Next slide. So what I was talking about is a standalone tool, which is per se very helpful, but the real power comes from integrating this CE grade clinical decision support into other systems. So the end game is that you're having AI scribe system, and this combines with our tool. We're integrating it into clinical information systems. We are integrating the real world evidence together with the world evidence. Our database is world evidence, but we can combine it with patient-specific data, with organizational data, and with real world data. And to combine this, contextualize is much better, and you could simplify to say it's a better form of a pre-prompt then, but the output then is a better contextualization, but the output then is on the basis of world knowledge or contextualizes. And we believe this is the ingredients that make those type of AI applications very explainable, but also very helpful. Is there one more slide? I think I've come to an end with my presentation. With the take-home messages. So I'm strongly believing that AI has extremely transformative potential, but it has to be adopted into the system where there are existing pathways, existing workflows, with care and with much explanation, and it has to be explainable. So the trust building and the legal liability fulfillment are two elements which we have inbuilt with Valmed, and this is our starting point. And when it comes to medical students, we have some here in the audience and one as a speaker. They are particularly vulnerable to misinformations. They are so since the internet. They are even more so now with the advent of AI. So it's very difficult to decide on what you trust on because it's so easy. And this is why exactly we are trying, Cora from my department will speak to that, trying to integrate this already in medical education. And with this, I hand over to you, Aaron, back to the moderation.
Thank you very much, Heinz. We'll now move on to Meenakshi's presentation, and she's going to be talking about the use of AI in clinical practice and research. Meenakshi?
Yeah, sure. Hi, everyone. My name is Dr. Meenakshi Jala. I'm an academic clinical fellow at King's. First of all, thank you so much for your time today. I appreciate it's kind of 4:35 p.m. where everyone is. So really kind of honored to have this discussion because it's such a topical subject. So I'll do a quick kind of whistle-stop tour of the research that I've been involved in. So it's essentially about the use of AI in clinical practice. And I've I think since I graduated, all the research projects that I've worked on have been in and within AI, and that's been a very conscious decision because what Prof. Weindel just mentioned, you know, we're at this point where there is a risk of becoming de-skilled, and so you either become skilled at what the new kind of developments are, or you're kind of lost in the wave. So the current research that I'm working on at the moment is with King's College London, and it's also being supported by Wellcome Trust. And essentially it's using large language models in healthcare evidence synthesis, and the project is called Solace AI. What this will do is create kind of real-time evidence synthesis to support policy and kind of responses to climate change emergencies in kind of the world. And that's why our project is kind of globally supported. We've got research institutions from Boston, Ethiopia, Amsterdam as well, I think, and obviously London. And essentially Solace AI will be kind of a database where you type in a question, for example, if there's a cholera outbreak, and it will come up with a very rapid evidence synthesis that researchers, policymakers can go through to come up with a solution on how to deal with the problem. And I think the challenges are quite similar to, I guess, what you've heard from everywhere. It's a standardized challenge of kind of hallucinations and consistency, and that's what we're finding with our research at the moment. So what we're doing is evaluating models first before building our own components for Solace AI. And so focusing a bit more on the challenges, as mentioned, consistency. So, you know, you type in a specific prompt, the same prompt can yield different results, which obviously is, it can be quite detrimental when it comes to kind of the healthcare profession and the medicine profession. Hallucinations obviously is a huge thing, especially with citations. And obviously when there's hallucinations, that erodes trust. So we really need to make sure that user confidence gets increased, and the way that we need to do that is by obviously combating those hallucinations. And lastly, more so on kind of method transparency. So where exactly is data being pulled from? And we need kind of explicit quality appraisal around the data and the synthesis methods. So we're focusing on those challenges, and we're looking at kind of automated ways to detect these logical inconsistencies. And that's where the research is focused on, and that's what the research output's going to be on for the next few months. And one thing that I really want to touch upon here, especially with large language models, a lot of the large language models pull data from Western index literature, which therefore means that there is a huge bias. And I'm really grateful for kind of countries like Ethiopia and other countries being involved in this, because what we'll then do is pull data from local journals and databases and really address that bias that exists within the current healthcare LLMs. So that's with King's College. That's the research that I'm working on at the moment. But back, sorry, Aaron, next slide, please. Back in 2024, I also worked with Imperial College London, and here I looked at protein-mediated trajectories in septic shock patients and identified these using unsupervised machine learning. So whilst the topic of this webinar is how our young doctors using AI to kind of prompt AI, and I don't know, I don't fully agree with that. I think we're quite kind of developed in what we're doing, and thankfully the rise in ChatGPT is just giving more of a spotlight to all the work that doctors are doing in this space. So to kind of simplify this, this is a piece of research that essentially looked at common groups within the septic shock patients. And why was it done? So I wanted to figure out whether there were subgroups within this kind of really large data set to see if we can come up with certain patterns that exist. So I used R as a coding language to come up with a model that looked at those specific protein-mediated trajectories. And class clustering was used to show distinct groups within the protein mediator. So as you can see here, you've got MCP, which is a protein mediator. And as expected, as time progresses, those the MCP decreases with time. And you can see some of my latent classes over here, and we can see that there's two distinct groups within the group of patients that I used the data from. But what's next slide, please, Aaron. What's really interesting is that actually through this process, I also found that there were certain protein mediators, such as BNP, which is essentially released when the heart's under a bit of stress. Some of these protein mediators actually increased with time. And why is this really important? Because it allows us to predict what a patient might, what their kind of health might behave like with time. And when we have this prediction, we can obviously then preempt what treatment we might give them. So if they are immunosuppressed, then we might want to give them CG-CSF. If they are kind of very, if they've got a very inflammatory reaction going on, then you look at giving corticosteroids and things to calm their inflammatory systems down. So I think that's really, really important. And this piece of research is still being continued by Dr. David Antcliffe at Imperial. So if this is something that you're interested in, I would highly encourage you to touch base with him. But yeah, that rounds off my presentation. And what I really want to just kind of hone in on is there is so much that's going on within the AI space, and it's just now that we're kind of coming to see exactly what's being done. And my favorite quote is, "Necessity is the mother of invention." So I think we're just going to see a rise in more and more of these things, and I'm really excited, actually. But yeah, thank you so much for your time. And if there's any questions, feel free to email me.
Thank you very much, Meenakshi. Yeah, very interesting what you said about Scope AI and consistency in the answers you got back, which was something that Heinz touched on as well, and particularly the point about bias of information, your sources of where the AI is sourcing information from. So it's maybe something we can discuss with Heinz in the panel discussion about validated source of information, not creating those biases. So we'll move on to Cora's presentation. It's going to talk about AI in medical education. Over to you, Cora.
Thank you, Aaron, and hi everyone from me. I'm Cora Koch. I'm a neurologist at the University Hospital in Freiburg. And I'd just like to give a short overview over like the general possibilities of AI in medical education, or maybe use cases also, and then focus on two things that I'm especially interested in. Could you show the next slide, please? So I think it's good for the beginning, because often when we talk about AI in medical education, it kind of all mingles because it's used in different ways, sometimes at the same time. So for me, there's sort of three buckets that it can be used for. One is AI just as a tool to increase efficiency for educators, which is similar to how AI is probably used in almost all professions by now. So for medical education, for example, it's easy and quick to generate case vignettes using LLMs or even multiple choice questions. There's a lot of data already that these questions are similar to human generated questions, and that's just a question of making education more efficient. And then obviously there's AI as content, because as we've heard now, it's already being used in the world, and there are several dangers of using it without being fully informed about how it works. But also there's obviously just ways it's being used in different domains such as research or imaging, where it's just important that for clinical practice, we know what exactly AI can be used for. So that's the bucket of AI as content. And then there's also ways to use AI as a tool to improve learning for students. So to change the way we do medical education and to ideally improve learning for students, because all of this is very new. We don't yet know whether it's truly an improvement in many ways, but I see a large potential that it can improve medical education if we are aware of certain pitfalls. So Erin, could you continue? The two use cases that I see as most, or that I just find most interesting to me personally, for changing the way we do medical education is the way we can use it to do scalable simulations, and also to use it for individualized feedback. Feedback is one of the most important things for learning at all, and there are studies upon studies that say that it's just there's not enough feedback during medical education, and LLMs offer a great way to change that. And the content of AI that I'm most interested in is sort of how it can be used to teach clinical decision making, or also support clinical decision making, which is already sort of the mix that I was referring to earlier. Next slide, please. So there are a few challenges of how AI is being implemented or can be implemented in medical education. One thing is that obviously educators sort of need to teach and learn at the same time, because for one, it's just a very rapid development and it's hard for anyone to keep track. But obviously, it's different how much different educators are motivated on their own to sort of to inform themselves about AI. So we sort of need to find new ways of how we do that at the same time, which probably also means being humble sometimes, that sometimes our students will be ahead of us in certain areas. Then obviously there's the problem of hallucinations, or the AI not knowing relevant or not using relevant clinical context information, not being able to integrate it. And so the danger of wrong information being provided by an AI tool that is used in education. And that's obviously something that can be mitigated with tools such as Proformate, which are validated, certified, and where like the output has been evaluated. And then there's the problem of DN misskilling, which has sort of been alluded to, but I think I'd like to maybe explain it in a little more depth, because it's something that I think is not yet solved. So, or we don't know yet how this will develop. And basically what it means, that, I mean, de-skilling is the idea that maybe using AI for certain processes that you didn't use it before, it just means that you will lose these skills that you had before. Like there's been a study on colonoscopies where the gastroenterologists were not as good as at seeing the relevant adenomas after AI was introduced as they were before it was introduced. So this is something that is relevant even to people who are already far in their training. And misskilling and also never skilling is something that's maybe more relevant for students who are, or doctors at the beginning of their career who are still early in their career, and refers to the fact that by using AI, it's possible that certain skills that we used to take for granted that you will learn them during your training will maybe just not be learned, because they are now so efficiently being done by AI. So this is a risk even with using validated information. If you're still in the process of learning, but you rely on the AI to tell you your differential diagnosis, to tell you what exactly you're supposed to do now, then possibly it will happen that you just don't learn how to do this on your own. And this is, I think, a development that we'll need to observe. It depends. Sort of, it's unclear whether this will happen at all, and it's also, if it happens, it's obviously unclear whether it's such a horrible development, because if the AI can do this for us, the question is why we still need to know. In other technologies, this is also something that obviously happens, that probably people were more skilled at using their stethoscope 50 years ago, when we didn't have an ultrasound available as promptly as we do now. So could you show the next slide? Exactly. So those are some of the challenges, and now to some of two of the ideas that I think will be very promising for improving education is one, the use of large language model-based chatbots as virtual patients. So for those who did not have a medical education themselves, it's very common to use simulated patients to practice all kinds of medical skills, mostly communication, but also clinical reasoning and like the clinical examination. And this has been tried this is a technique that is great and students learn a lot, but it's obviously also very expensive and needs a lot of resources. And LLM-based chatbots can sort of solve these problems, because it's very easy to generate a simulated patient. They are able to converse in natural language, so they can be used and are already being used to train communication skills and clinical reasoning. We have some data already that students accept this type of teaching very well. It's not as clear yet whether they are actually able to teach these things, especially with communication skills. Obviously, there are some questions so far. They've mostly been used text-based, not orally. And whether they're able to improve reasoning skills has not really been studied well to date. So next slide, please. And as I already mentioned, feedback is one of the most important parts of learning, and often, sadly, not given enough during medical education. And this is also something that LLMs are already very good at, as they are able to give formative, qualitative feedback, in the sense that they can, for example, as a virtual patient, they can, after they interact with a medical student, they can give feedback on the interaction. They're also able to give feedback on videos of procedures or on simulated oral exams. And there's some data that their feedback seems to complement rather than substitute feedback from clinicians. So they're very good at giving structured, complete feedback, but maybe not as good, at least not yet, at mentioning the clinically truly relevant facts. But that complements feedback from clinicians, who are sometimes not as good as giving structured feedback, and might not be as true to the guidelines as the LLMs. And it's also possible to use LLMs to give quantitative feedback, so to actually give grades, and that's already comparable to human examiners. So there's a potential also to use that for high-stake exams, and maybe change the way we do exams. At least in Germany, the medical school is very based on MC questions, but LLMs are also able to analyze text-based questions more quickly and these text-based answers. And it's obviously easier to examine more higher level cognitive processes using questions like that. Next slide, please. And next slide. So basically the take-home messages are that AI needs to be integrated into medical education. I think that was already clear from the two other presentations. And in my view, it definitely has the potential to positively transform medical education, but obviously it needs to be used wisely. So we need to be sure that we are using the right tools and aware of possible misinformation depending on the tool we use. And that would be my ending. Thank you very much.
Great, thank you so much, Cora. There's a lot to get through in terms of questions. I'll ask Frank to join us, and also Tim. Again, reminder to submit your own questions through the question icon at the top of your screens. Tim, you've been sat there patiently listening in. I'll aim the first question to you. So when you have a clinical question, what's your first instinct? Is it textbooks, journals, Google, AI tools, or social media?
Hi, yeah, also maybe welcome from me, and yeah, I'm Tim Schwer. I'm also from Freiburg. I'm now in the 5th year in my medical training, and I'm almost finished there. And yeah, about that question, it kind of depends on the clinical question I have. If it's easy to answer and I know where to find it, then I use journals or reviews. But if it's a question that I really don't know how to answer, then the first thing I do is I use Perplexity or another AI that's available to ask them what they think. And after that, I ask them also to give me the sources they found and look up their sources, and then I hopefully find an answer to that.
Thank you. So something that Heinz said as well then is knowing what the question is and the context and where to go for the source of information. So I guess following on from that, you heard from both Cora and Heinz about de-skilling, mis-skilling, misinformation. So for you as a student growing up in this, or educating in this world, do you feel that your training's preparing you well to critically assess digital AI-driven medical content? Are universities preparing you for AI-assisted clinical practice?
So if you have asked, if you would ask me 2 years before, I would have said absolutely not. And now I would say they try to, but they're not yet succeeding in doing so. Last year, the University of Freiburg did make some policies about how to use AI in research, and that's really helpful because now we have like a guideline how to use it, but before that we don't had much to do with AI. And also in education right now there is not much use of AI, and also not much use of encouraging to test AI, but it comes more and more, and more faculties and more and more educationers are using AI and helping us to understand what's good and maybe also how to use it properly.
Okay, so there's maybe a gap there, but I guess that's to be expected with you as the test case, if you like, of using AI tools in education. So maybe Cora, are your students already experimenting with AI co-pilots? How do you guide them to use them responsibly, and can you tell when they are using them?
I think they are already using them. I don't think I can always tell, though. I feel like, because I think there is, I mean, you showed in the beginning that there's still a somewhat low trust in AI. So students do tend to say, oh, so I actually looked this up, and it's not actually that hard to in their face-to-face interaction to tell whether they used it. We do have some online exams that are multiple choice, and obviously it's impossible to tell whether they used it for that purpose. We sort of felt like they did in one exam because all of them got one question wrong in the same way that we assume was probably due to AI use, but could also obviously have been due to communication between the students.
Okay.
Yeah.
So they're allowed to use it. You don't stop.
No, they're not allowed, but it's not. I mean, they're not supposed to, but it's not supervised. So.
I see. Okay. Okay. So maybe similar question to Meenakshi then for your junior colleagues. Do you find that they're turning to AI tools or other such digital platforms for clinical decision support? And have you?
And have I?
Yeah.
Okay. Yeah, no, I think amongst my cohort, I think we're probably a bit more kind of creatures of habit, and more of us turn to PubMed and your classic journals when we've got certain questions. But I think where AI is being used is, for example, if there is a broad question and we need kind of a light to just pinpoint us to the right direction, that's where LLMs are really being used. But the actual kind of trusted data that comes from your journals. Yeah.
Okay, thank you. Maybe I'll turn to Heinz. You talked a lot about trust in sources of information, and there's a recent paper by Ginassi et al. Talking about a framework of the trust dynamic when AI is integrated into the relationship between patient and doctor. So have patients' use of AI changed your approach to clinical consultations, and have we just moved on from Dr. Google? So are you seeing patients come in with ChatGPT answers or suggestions for you to consider?
That's a very interesting development, and you're hitting the nail, because this definitely happens. So it's relatively easy and low threshold that you basically consult ChatGPT and come in with a, let's say, treatment or differential diagnosis plan, and you're confronted with what has ChatGPT said, very similar to what has happened with Dr. Google already said. And here the problem starts, because this is sometimes helpful, but very often it's not, because it depends on how you prompt and what the medical condition is. I once heard with a very rare and weird diagnosis that the patient that consulted ChatGPT was particularly happy that ChatGPT was so creative in treatment plans. This is exactly what you're not easy digesting with as a doctor. Yes, we have to deal with this, definitely. My answer to that would be probably we can't avoid it, but this is definitely not the path we should go. Even beyond, I mean, one of the most worrisome use cases of ChatGPT is psychological or psychiatric consultation, that the ChatGPT basically replaces a communication lacking appointment situation with a psychotherapist also. So this is there's more and more cases where this can really get dangerous. On the other end, this is exactly what we haven't yet inbuilt, but to have something like a validated source of literature in a patient communication way conveyed into a patient journey, this is something Valmed could also deliver, but then it would be a controlled way, and would be a controlled way also where a doctor would be in the loop.
Okay, thank you. And there's a question actually in the chat about liability, and you covered that a little bit in your presentation. So there's a new international partnership for governance in AI called Polaris GM, but you mentioned that a lot of doctors, patients are using ChatGPT. But how do you benchmark the output from these systems and them being safe to use in the healthcare setting? So you talked about liability, I guess, ultimately resting with the physician. Is that correct?
Yeah, look, I mean, you said it in the end, it's resting with the physician, and how they basically come to their decision is, in a way, their responsibility. If you're working in certain environments like hospitals, there are bans for AI tools because they must not be used to support diagnosis and treatment because they don't fulfill any liable requirement. If you're in the Wild West, then there is not that much that you can do to prevent this. And then it's the responsibility of the doctor. And this is why you have to provide solutions and alternatives. One is this CE grade, where you have to undergo a validation, and the other is data security issues that you should be aware of. In a way, with tools like ChatGPT or also open evidence, you're openly disclosing your maybe most secret or secret patient related information. This is all aspects we're not that aware maybe in some contexts, and as a medical student that might not matter that much, but if you're talking about real patient situation, it gets pretty serious. And that's one thing I would like to flag very clearly, that this is a problem. The low threshold of use sometimes makes you overlooking what the dangers and threats might be.
Okay, thank you. Tim, I'll bring you back in. You mentioned that you do go to published information as your let's say preferred source of information, but what would you like to see from publishers or educators or even regulators to better support the next generation in navigating this information landscape?
Yeah, like Professor Windel also mentioned, the medical knowledge is exploding. So if I look something up like 5 years ago when I started to study medicine, and I'm looking it up now, there are like 10 new medical options I can now use to treat the same disease that was 5 years ago, or in other cases the same disease or the disease 5 years ago isn't the disease now. Now there are 5 subtypes. And they're all treated differentially. And so to navigate those, it's getting really hard, because after our medical education and then you start treating patients and you start your rotation in Germany, and you start to choose your specialty. And if you want to navigate those, you need somehow an AI that helps you find the actual information most fast and the best way. And that's not always the newest review, because sometimes the review is so complicated and you need to use another review, and then it's 2 hours later, and you don't have time for that in practice. So I think an AI that uses validated information and you can source for that what you need right now, that would be best, like Professor Walmit, for example, or other AIs that are also existing now.
Thank you. Frank, any thoughts on that from a publisher's perspective?
Yeah, from a publishing perspective, of course, the use of LLMs are coming full speed. Of course, researchers are using that in their writing process. All publishers, they have AI guidelines on how to deal with that. So it's okay when it comes to formatting, editing, language corrections, and so on. So that's fine. But of course, when it comes to editing or changing any data or generating images and so on, that is not allowed. So every publisher would have AI guidelines on their website. And I think as a publisher, for us, it's very important that we have very good research integrity checks. As everyone knows, it's a huge issue with paper mills, fake papers being submitted to journals. So our task is to make sure that what is published is of high quality, and that is what we work on every day, to make sure that the editors-in-chief, editors, and also the tools we provide in this system, that we have very good integrity checks, that in the end the LLMs will have reliable peer-reviewed material to digest.
Thank you. I'm sure we could talk for another hour, but I'm sure you all have got more important things to do, like treat actual patients. So I'm going to hand over to Frank now, who's going to wrap up and give us an overview of some of Cargo's services. Frank?
Yeah, very, very close. Next slide. Yeah, so this is the second cargo debate. There will be a new one. The exact topic and date is still to be confirmed. Next slide. And before we close the session, I just want to mention the type of work we do. We provide at Cargo. So in addition to the peer-reviewed publications, we have 95 medical journals. We also offer scientific outreach solutions and medical education. Next slide. You might have heard about the Fast Facts Medical Information Series for healthcare professionals and patients. So we got podcasts for on-the-go learning, animations to bring research to life, and we have the Fast Facts books for getting into new topics quickly. And we have pilots running across also e-learning and how to integrate, for instance, the chatbots with books, and for courses, multilingual courses, how we can implement lip avatars and lip sync. You've probably seen all these tools. For instance, if a course has to be in 20 languages, have tools to generate that quickly. Next slide. Here's a selection of our work. If you're curious about what we do, let's connect. I would like to thank everyone here today for your time and energy. Dr. Cora Koch, Dr. Manaski Yala, Tim Schwer, Professor Heinz Windel, and of course, Aaron, thank you so much. So until next time, keep exploring. Try to keep up with AI as good as you can. This is changing, like it's breathtaking how quickly everything changes, and continue to make a difference in healthcare. So bye-bye, everyone. Thank you so much. Have a nice evening.